Welcome back to our episode of Crowncast, and this time, as you can hear, we have a very special episode in English. And of course, we're gonna welcome again Dr. Djelamda, who we thank a lot for always answering our calls for episodes and events. And good morning.
Good morning. I'm so glad to be with you for this second podcast. Before we start, I have to thank you, as usual, for your efforts and for your motivation. It's a pleasure to have a student like you.
Thank you so much. Today's subject is Oral-Antral-Communication. Our first question, an easy question, can you explain what is the Oral-Antral-Communication?
So the OAC, it's a very common complication. To explain what is OAC, so we have the maxillary sinus, which is the largest of paranasal sinuses, which is pyramid-shaped. So this sinus is a cavity within a bone. So normally there is no communication with oral cavity. It's because of that we speak about oro-antral communication. So oro, it's about oral cavity. Antral, it's another name of the maxillary sinus. So when we have this communication, it's an unnatural space. It's an abnormal space between the oral cavity and the maxillary sinus. And the major problem is that if it's untreated very quickly, it can epithelialize and turn to an oro-antral fistula. Even worse, this sinus can be infected, and generally it's the case.
Okay, so you mentioned that it's an abnormal thing. So what are the common causes of its occurrence?
Okay, very nice. So there are many risk factors of OAC. It may be the result of anatomical factors, especially when we have the closeness of the root type to the floor of the maxillary sinus. In this case, the bony portion above the root type is very thin or maybe absent. In this case, the OAC is inevitable during the extraction of the tooth. And even when we have a divergent roots with a huge sinus, we have also pathological factors. When we have a periapical lesion that has eroded the bone wall of the maxillary sinus, we have the iatrogenic factors, and it's the most important part. So here, it's caused by the dentist. Generally, when the dentist tries to extract the tooth with no visibility, when he uses no methodologic way to extract the tooth, in this case, in case of extensive bone removal for extraction of an impacted tooth, we can have a displacement of an impacted tooth or root type into the maxillary sinus during a removal attempt. So we have to pay attention to not be the cause of OAC.
Okay, interesting. So are we talking about one type of OAC or multiple types? And if so, can you mention that?
There is many types of OAC. So when we speak about the localization, we have the alveolo-sinusal, the palatal sinusal, and the vestibulo-sinusal. And when we speak about the duration, we have the immediate OAC, just after the extraction. We have the recent OAC, and we have the old OAC. And for me, if it's epithelialized, it's an old one. And when we speak about diameter, we have the punctual communication, very small communication. We have the medium communication, less than 5 or 6 millimeters. And we have the large one, more than 7 millimeters.
So, to our fourth question, how can we diagnose the oral-antral communication?
Okay, very nice. So here we can have two situations. It can be our patient during the extraction, or a patient that we receive in emergency. In this case, we need a history. Generally, the patient may say that there was a recent extraction, a fluid coming out of nostrils, especially when he drinks something. For clinical exam, we will see an inhaled socket. And the most important part, it's when it's our patient. Why? Because we want to diagnose the OAC immediately. So here, the diagnosis of OAC can be made by several ways. First of all, we have to examine the tooth once it has been removed, especially if there is a section of a bone adherent to the root ends of the tooth. Pay attention, we have to pay attention. So here there is a communication. And also we have the Valsalva test, or the nose blowing test, to confirm the presence of a communication. This test involves pinching the nostrils together to occlude the patient's nose and asking him to blow gently through the nose while the surgeon observes the area of the tooth extraction. So if there is a communication, if a communication exists, there will be a passage of the air through the tooth socket and the bubbling of blood in the socket area or on the dental mirror, and even we can hear a characteristic sound. So with this clinical exam, we can diagnose the presence of OAC. And of course, there is special investigations. Generally, the OPG is the first exam that we can explore and we can approve that there is a communication. But of course, it's not sufficient to examine the maxillary sinus and even to evaluate the diameter exact of the communication, or when we have a projection of a root into the sinus. So it's the indication of a computed tomography or CBCT, especially in the case of sinusitis. We will see clearly the thickness of the maxillary sinus, which is invisible with OPG.
Okay, interesting. And since you mentioned the Valsalva maneuver, we arrived to a very important point. What is your opinion on the fact that on one hand, the Valsalva maneuver can enlarge an oral-antral communication, and that on the other hand, this maneuver is essential for the diagnosis?
Oh, yes. It's a good question. So, it's about pressure. So, if there is no communication at the beginning, or if there was a very small communication, forceful blowing poses the risk of creating a communication or enlarge it. But listen to me. For me, yes, we have to do the Valsalva test because it helps dentists to diagnose the OAC, which is very, very important. But we have to do it once, carefully, with gentle blowing, and do not repeat it many times. Do not insist. That's it.
So let's imagine that I was in my clinic and I received a case of oral-antral communication, or I was the reason of one. How can I manage one?
Okay, so you have to know that generally, if it's a punctual communication, very, very small, so with a high quality blood clot in the socket, it will be okay, and no additional surgical treatment is necessary. But listen to me. The rule is, if it's a recent OAC, or more better, when we diagnose the communication just after the extraction, we have to close the defect immediately, and it's imperative. And generally, we use the buccal advancement flap, and it's indicated for small or medium size of OACs, and it's the most common surgical technique. It has many advantages, especially for its simplicity. The disadvantages are about decreased vestibular depth, and it may need vestibuloplasty. But for OACs, generally, it will have, or we will have a good result, especially if it's recent. And of course, the patient should take prophylactic antibiotics. Generally, we prescribe the association between amoxicillin and clavulanic acid. With analgesis and even a nasal decongestant, and of course with post-op instructions. And the most important rule is that we have to take sure that the sinus is not infected before closing the defect. It's the case for the old OACs. So in this case, we have to treat sinusitis before surgery. There are other types of flap, especially for oro-antral fistula. We have the palatal-based rotation flap. It has many advantages because there is no reduction of the buccal vestibule, less likely to break down, but it's difficult to reposition compared to the buccal flap, and also there is a risk of ischemia of the flap. We have also the buccal fat pad flap for closure for large posterior OACs. We have the tongue flap, which is used rarely. And in the case when we have a displaced root, The Caldwell lock is indicated. We have to raise a mucoperiosteal flap, cut a window into the sinus, remove the displaced root, and close the flap.
Okay, very interesting. You also spoke about the post-op instructions. So can you tell us more details and especially what should the patient avoid exactly?
Okay, yes, it's true. It's a good point. After surgery, the patient should avoid nose blowing for the next 3 weeks because it will force the air through the hole from maxillary sinus into the oral cavity. The patient should avoid sneezing as much as possible, and if it's inevitable, the patient should sneeze with his mouth open. He should avoid disturbing the area that has been surgically treated. Do not see if a hole is present. Do not forcefully spit for several days. Do not smoke for several days. Do not use a straw. Eat only soft foods. And of course, take prescriptions as directed.
Okay, okay. To our eighth question, in what ways the interdisciplinary collaboration between dentist and the ENT specialist is crucial in managing the oral antral communication?
Yes. Generally, we collaborate with ENT specialists to treat sinusitis because, as I said, it's a rule that we have to treat sinusitis before we close the defect. And they have their own methods. It's not just by prescribing antibiotics. And for some case of surgery, especially if it needed general anesthesia.
Okay, and for our last question, we always say that preventing something is way better than treating it. So simply, how can we prevent an oral antral communication?
Yes, exact. And it's the most important part. In order to avoid OAC, as well as the displacement of an impacted tooth or root into the maxillary sinus, first, it's important to do a radiographic examination for the region surrounding the tooth to be extracted. It's a very important point. Careful manipulation with instruments, especially during the luxation of a root type of a maxillary posterior tooth. Careful debridement of periapical lesions that are close to the maxillary sinus. Avoiding it's the most important point. The rule it's to avoid extraction of a root type if there is no visualization of the area.
Okay, thank you so much for all of this very important information. Sadly, we came to the end of our episode. See you again to a new episode, and you can suggest us what you want in the other episodes as the subjects. Thank you again so much.
Thanks for you. It was a pleasure for me to be with you today. I hope that it was an interesting discussion, and see you in other activities, inshallah, if God will.
Inshallah.